Hello friends. So in today's session, let's discuss about pre-labor rupture of membrane. So you might have commonly encountered two terminologies. One is PROM and other is PPROM. What is the difference between these two? PROM is basically pre-labor rupture of membrane. Just like the name denotes, pre-labor means before the onset of labor. So before the labor has actually started, the woman has started leaking, there has been a rupture of membrane. So pre-labor rupture of membrane is the rupture of membrane prior to onset of labor. Onset of labor. So in labor, as you know, in labor there would be cervical dilatation, cervical effacement, uterine contraction. All these changes have not happened. Suddenly she has come to you with leaking PV. There is fluid coming or leaking through the vagina. Associated with that, there is rupture of membrane. This is pre-labor rupture of membrane. Whereas preterm pre-labor rupture of membrane, PPROM, as the name suggests, it is preterm pre-labor rupture. That means these changes are happening before 37 weeks. So it is the rupture of membrane prior to onset of labor. Same thing, prior to onset of labor, but it is happening before 37 weeks. Happening before 37 weeks. So what are the clinical features that you see? Usually women complain that there has been some leaking. There is some gush of fluid through the vagina and that has soaked her clothes. This is the typical history that you're going to get. That there was a leakage that happened from below that has soaked her clothes. So there is gush of fluid or even continuous dribbling of fluid could be a history that the patient presents with. Whenever patient presents to you with this history, you are going to check, is she having any contractions? You will do a per speculum examination. You will see, is she actually leaking? Is it the amniotic fluid coming out? Or is it some other fluid? What other fluids could be there? Sometimes it could be the urine that is actually leaking out. Many a times in this gravid woman near term, this pregnant uterus presses on the bladder, and sometimes when she coughs or sneezes in all these things, the urine can just come out. Okay, so it could be urinary dribbling, or sometimes it could be the excessive vaginal discharge, or it could be some infections in the vagina which is actually causing this discharge. So you have to do a per speculum examination. You will just put a speculum inside the vagina and you will see what is she leaking. So again, in an instrument session, I have taught you an instrument like this, which is your SIM speculum. So you are going to insert the SIM speculum, retract the posterior wall of vagina, have a look at the cervix and see, is the fluid coming out through the cervix? Is it amniotic fluid? Okay, you will have a look at it. So you have to also check for the smell, the color of the amniotic fluid. If you see that there is a smelly amniotic fluid coming out, smell in the amniotic fluid, abnormal smell could be suggestive of an infection such as chorioamnionitis. Or abnormal red color might be seen if there is any associated abruptio placentae. So you will do a per speculum examination, retract the posterior wall of vagina. So suppose it's the vagina, you will retract the posterior wall and you're going to see what kind of fluid is coming outside. Suppose there is no fluid, then you are going to ask the patient to cough or do a Valsalva maneuver. Again, this can help you to visualize the fluid that is coming through the cervix. Okay, this is what you're going to do. So let's write the key points. In clinical features, the most reliable feature is that you are going to get a history of gush of fluid. Either it could be dribbling or continuous leakage. So she will complain of gush of fluid which soaks her clothes. So this is a typical history. She will say that there was gush of fluids and all her clothes were soaked in that fluid. Alright. So the definitive diagnosis is basically by doing a per speculum examination. In per speculum examination, you can see the fluid coming through the cervix, coming through the cervix into the vagina. Again, you have to have a look at the color, the smell, because foul smelling fluid can be associated with chorioamnionitis. A red colored amniotic fluid could be suggestive of abruptio placentae. Suppose it is inconclusive, then you are going to ask the patient. If you are doubtful, it is inconclusive, you will ask the patient to cough or perform a Valsalva maneuver and again check for leaking. You will check for leaking per vagina. Alright. Will you do a digital per vaginal examination? PV is avoided in these cases because again, when you are introducing your fingers into the vagina, the risk of infection increases. Already after rupture of membrane, this protective membrane has gone. She is at high risk of infection. Again, you don't want to put your finger inside, again risk the chance of infection. Yes, we use a gloved finger, still whenever we do a digital examination, the risk of infection increases. So we want to avoid digital examinations in this. So as we discussed, the other differential diagnosis could be a urinary leak, a vaginal infection, or even vaginal secretions. These vaginal secretions are usually acidic in nature, whereas these amniotic fluid secretions are more alkaline. Urinary leak, again, urinary leak from the site you can differentiate. Also, there could be smell of urine which is there, okay, in contrast to this. Coming to the investigations that you're going to do to differentiate between these various secretions or other things such as urine leakage, one important test is Nitrazine test. Usually in clinical practice, we just make the diagnosis clinically, okay? But if at all there is some confusion, we can rely on these tests, which is not very commonly performed. First is this Nitrazine test. Nitrazine test is just like a litmus paper test, which we dip in the amniotic fluid. And the amniotic fluid, if it is actually amniotic fluid, the color will become blue. Color is blue, whereas with cervical secretion, cervico-vaginal secretions, which are acidic, the color would be red. Here it is blue, whereas cervico-vaginal secretion, the color is red. Next, coming to Fern test. So we have discussed in detail about Fern test along with the topic of infertility. So basically the main principle is that there is more ferning seen when the main hormone is estrogen. Once progesterone takes over, the ferning disappears. So usually in the initial part of the cycle, in proliferative phase, there is going to be estrogen and there would be ferning. In the secretory phase, it is predominantly progesterone. There will be absence of ferning. So even in pregnancy, progesterone is present. So vaginal secretions do not show ferning. But this amniotic fluid, which actually has high levels of sodium chloride as well as protein, they are going to show ferning. So Fern test is positive with amniotic fluid. Fern test or ferning is seen along with amniotic fluid. Next, you have swab tests such as Amnisure kits are available, which can again help you to say whether it is amniotic fluid or not. Genital tract swabs are usually taken because, as we discussed, the risk of infection is there. Whenever patient has PPROM, we usually take vaginal swabs as well to detect any infection which is there. Okay, so these are the investigations that we perform. Finally, you can do an ultrasound. Ultrasound will tell you what is the gestational age of the baby, what is the liquor around the baby, and if there is any fetal distress, again, which can be seen with biophysical profile. So all these things can be checked along with ultrasound. We don't usually perform ultrasound to check for cervical length in case of this PROM. We do cervical length measurement in preterm labor, but the role is limited in case of preterm pre-labor rupture of membrane as well as pre-labor rupture of membrane. Coming to the management of these patients. So, management actually depends upon the gestational age. Again, we divide the patients whether they are more than 37 weeks, 34 to 37 weeks or less than 34 weeks. Because at this time, we are finally balancing two things. What are the two things? If I deliver the patient too early, there is complication related to prematurity. If I deliver the patient too late, there is more risk of an infection to set in and problem to happen. So we have to balance out both these things and manage the patients accordingly. So let's see how will we manage the patient clinically depending on the period of gestation. If patient presents to you more than 37 weeks, so she's already term, I'm not much concerned about the prematurity part, right? We are not at all concerned about the prematurity part. Baby is well developed. So at this point of time, I need not give the patient any form of steroids. I need not give the patient any form of tocolysis to decrease the contractions, right? In these patients, we can induce the delivery. Do we need to do a cesarean section? No. We just have to initially induce or even accelerate the delivery by induction of labor, and vaginal delivery is actually preferred. Many a time students tend to jump into cesarean section as soon as even minor things happen. Leaking PV, these PPROM patients are not required to undergo a cesarean section. You induce her, she will go into labor and try to deliver as soon as possible. We will give prophylaxis or some antibiotics to prevent infection from organisms such as group B streptococcus, not for all individuals. If the leaking is there for more than 18 hours, she has leaked, maybe she has leaked now and 18 hours have passed, still she has not delivered. In those situations, I will give her some antibiotics which is known as GBS prophylaxis, group B streptococcus prophylaxis. I'll tell you what are the indication of GBS prophylaxis and what is GBS prophylaxis drugs in a short while. But understand that in this category, I will also give some prophylaxis. So sometimes they can give a clinical scenario. Patient come to you at 37 weeks. What all are you going to give? One option will contain tocolysis, one option will contain something else. So you have to choose. These one option will be definitely having cesarean section. So understand that method of delivery is vaginal delivery. Induce the patient, and if she goes beyond 18 hours also, you're going to give GBS prophylaxis. Now coming to the next category, that is between 34 to 37 weeks. Here again, we have a tug of war. If I deliver too early, risk of prematurity, too late, risk of infection. So here we have to weigh the risk and benefit, monitor the patient well. I'm going to monitor her for signs of any form of infection, such as foul smelling, amniotic fluid is coming out, the mother is having fever, tachycardia in the mother, uterine tenderness, pulse rate of the mother. We are going to monitor all these things well, and if at all there is some signs of infection or some doubt, we will deliver as soon as possible. So in this category of women, there is role of expectant management, that is do nothing, wait and watch, or deliver the patient. Okay, there is both these, we will weigh the risk and benefit. There is no one right answer. But what all am I going to do at this? I will give steroids. If the expected delivery is going to happen within 7 days, we have to start the patient on steroids. We will give the patient GBS prophylaxis if indicated. Finally, there is no role of tocolysis. There is no role of tocolysis at this point of time. Coming to the next scenario, patient less than 34 weeks. Patient come to you less than 34 weeks. Now there is no confusion. Here it was very clear. In the first scenario, deliver induction of labor. Here also it is very clear, don't deliver. Do an expectant management. Only in the middle part, it is in between. I hope you are getting the gist of it. More than 37 weeks, deliver by induction of labor. Less than 34 weeks, do not deliver, do expectant management. In between this, weigh the risk and benefit and deliver accordingly. So in this group of patient, you will admit the patient, give the patient everything. What all? Give steroids, give tocolysis for at least 48 hours. When the steroid coverage is completed, you will also give magnesium sulfate. As we discussed along with preterm labor, magnesium sulfate will help in neuroprotection of the baby. So you are going to give it if the baby is less than 32 weeks. Again, GBF screening is done. I'm going to take a swab from the vagina, see if there is GBS infection, and if GBS prophylaxis is indicated, I will give. Don't worry, I'm telling you the indications soon in the next page. So just understand in both these, all this, if GBS prophylaxis is indicated, we will give GBS prophylaxis. We might have to give antibiotic prophylaxis for these patients, and I will monitor the patient. The pulse rate, temperature, is there any foul smelling lochia which is coming out, fetal heart rate, any changes are the uterine tenderness, all these things are monitored. So you monitor the patient. This is how you manage. This is from Williams textbook as well. So this can come as a clinical question. Either they can give you any of these scenarios. So you have to consider the gestational age while managing a case of PPROM. All right. So as we are discussing, when will I give GBS prophylaxis? So first is woman presents with positive rectovaginal swab between 35 to 37 weeks. So between 35 to 37, I have done a swab testing. I put in a swab, took out the cervicovaginal secretions and we tested for that and it came out to be positive. Then we have to give GBS prophylaxis. This is the latest ACOG guidelines is saying this, American College of Obstetrics and Gynecology. And also as we discussed, if there is prolonged rupture of membrane beyond 18 hours, you have to give GBS prophylaxis. If the patient has fever during labor, intrapartum fever more than 38 degrees Celsius, or any time you have checked the urine of the patient and urine showed GBS bacteriuria, there was GBS present, group B streptococci was present, again you are going to give. Or if previous baby was affected with GBS, again you are going to give. So in all these scenarios where there is high risk of group B streptococcal infection, you are going to give this GBS prophylaxis. The drugs that you give for GBS prophylaxis is penicillin. Penicillin is given for prophylaxis. If the patient has allergy to penicillin, then you shift to clindamycin. Clindamycin if there is penicillin allergy. If the patient has high risk of resistance to clindamycin, if there is risk of resistance, then you give vancomycin. Risk of resistance, shift to vancomycin. So this is a simple topic where you can expect a clinical scenario maybe where you have to diagnose it or manage it accordingly. All right. So that was about PPROM and PROM. Thank you.